بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. Good evening everyone. This is Dr. Saad AlRabeeah, Chairman of Saudi Pediatric Pulmonology Association. It's our pleasure and honor today to have a very excellent presentation. And before I introduce our speaker tonight, I would like to thank all of you joining us today through this webinar, where we'll meet and to discuss very important issues in respiratory therapy, which is a very important part when you are dealing with any patients, particularly patients with respiratory problems. This part of seminar is part of the Saudi Pediatric Pulmonary Association learning in the era of COVID-19, where people, they cannot attend. So this is the excellent opportunity to meet virtually where we discuss. This is not the only, we had already preceded by 6 seminars, and we are continue, inshallah, to have another seminar for the coming 3-4 days. This part of effort is not a one-man show, it's a teamwork in the Saudi Pediatric Pulmonary Association, in the board of director, as well as the members who already volunteered kindly to participate in these programs. And also, it's part of the huge support from the Saudi Thoracic Society, and I would like to thank them for this support. We have 2 very well-known speakers in the field of respiratory therapy, and they are always supporting our society and other societies, of course. I would like to thank them, especially during these days where people, they are busy in the last 10 days of Ramadan. First of all, Dr. Khaled Alawam, who is the Assistant Professor of Respiratory Therapy and Chairman of Respiratory Therapy Program at NIV College in Riyadh, Saudi Arabia. And our next speaker will be Dr. Saad AlRabeeah, who is Assistant Professor of Respiratory Therapy from Prince Sultan Military College for Health Science in Dhahran in Saudi Arabia. Both of them, they are always very supporting and helping us when we are just asking them to participate. On behalf of everyone, I would like to thank you, Dr. Khaled and Dr. Saad, for your kind acceptance. And without any further ado, I would like to present the first speaker, and the first speaker is Dr. Saad AlRabeeah, who is going to talk about the non-invasive therapy, and then we'll catch after the presentation. So please, Dr. Saad, go ahead.
بسم الله الرحمن الرحيم. الصلاة والسلام على أشرف الأنبياء والمرسلين. First of all, I would like to thank the Saudi Pediatric Pulmonary Association for having me. It's an honor to be among you. Secondly, for this event, وأسأل الله أن يرحم الدكتورة مها الدباغ ويغفر لها ويسكنها فسيح جناته. Today, inshallah, we will talk about pediatric non-invasive ventilation as a general respiratory support modality, non-invasive respiratory support modality. And I will, inshallah, start my presentation with the common objectives. I hope you are seeing the presentation now. If there is anything, please let me know, or the voice is not clear enough, please let me know. The objective, we will talk about the terminology and concept of non-invasive ventilation, why and why not, and what's new in the literature in terms of the recent evidences and recent studies in the pediatric population, complication and risk, and summary of recommendation. So the new, I'm not going to say the new, recently it's non-invasive respiratory support is the term that is used when we are identifying or when we are describing something to deliver to the patient to not on a form of mechanical ventilation. Non-invasive positive pressure ventilation is one form. The other form or the other concept is continuous positive pressure ventilation, airway pressure, and the second is high flow nasal cannula. And this section, my colleague Dr. Khaled is gonna talk about it. One thing we want to mention here, unlike adults, for children and versus older children, children usually they have small airways, high airway resistance when we compare it to older children and adults. They have pediatrics, young children, they have a compliant chest wall. Usually they are which leads to low functional residual capacity. And sometimes in some patients, they have insufficient diaphragm function. So the benefits of non-invasive ventilation in this population is to stabilize the chest wall, improve or reduce work of breathing, increase tidal volume delivered to the patient, the amount of breaths taken in every single breath, increase the functional residual capacity, which in turn will improve oxygenation and keep the airway, keep the lung alveoli in the lungs open to prevent also atelectasis, and at the same time reducing the O2P. In another way, we are making or stenting the airways and splitting the airway open and reducing the resistance that may face in the younger population of children. Also, it will, as mentioned earlier, it will reduce the decreased work of breathing and improving the VQ mismatch and preventing reintubation in some population and avoiding also the endotracheal intubation. So in non-invasive ventilation, I want to differentiate between it and between the CPAP. Usually when we want to positively support, when we want to provide a pressure support or positive pressure support to support the patient while he is inhaling, we are providing him with a term called inspiratory positive airway pressure, which is the pressure that is support the inspiration while the patient is inhaling during the inspiratory phase. The expiratory positive airway pressure is usually called, when we are using inspiratory support, the expiratory positive airway pressure is called EPAP at this stage, which is keeping or maintaining the airways open to avoid any obstructions, or also to avoid any airway collapse, in which we are maintaining positive pressures during the expiratory phase. As you can see in this picture, it is clearly that we are having the inspiratory phase in this section, and the patient goes down exhaling, and we are maintaining a certain amount of expiratory positive pressure support, which is in this case can be called a CPAP. However, since we are supporting him during the inhalation phase, it is called bilevel or IPAP plus EPAP. So in terms of terminology, as mentioned earlier, the common use of CPAP or non-invasive positive pressure ventilation during inhalation or high flow nasal cannula is usually the three types of non-invasive respiratory support modalities. In this picture again, this is maybe more clear. We have normal breathing on the left side. This is how we breathe as normal people. When we maintain CPAP, we are just supporting, making continuous pressure available to the patient or to the child. In another way, making sure that the airways are open and we are preventing atelectasis and increasing the functional residual capacity. And usually CPAP is used with the patient with hypoxemia related to alveolar collapse or symptom associated with obstructive sleep apnea or upper airway collapse. And these are the major indication we use it. So why do we use non-invasive ventilation? Is usually used by clinician either to avoid reintubation, to avoid intubation, or to liberate patient from mechanical ventilation and avoiding reintubation, and for some patients who require continuous or temporary ventilatory support for any other reasons, depending on the physiological effects, which will determine the selection of therapy. So we don't use non-invasive ventilation in patient determined based on their level of consciousness. Maybe it will not, the patient level of consciousness will determine how to use the non-invasive ventilation support. If the patient is having facial trauma or having, for example, a pneumothorax or something that will prevent the use of non-invasive ventilation. Also in severe upper airway obstruction in some diseases and hemodynamic instability. This is maybe depending on the evaluation that's done by the physician and also with the help of the recommendations of the respiratory therapist. So let's look at the literature. What does the literature tell us about the use of non-invasive ventilation in pediatric population? So this study is a prospective randomized trial, controlled trial, non-invasive ventilation in pediatrics. And it is to compare the benefits of non-invasive ventilation with the standard therapy versus standard therapy alone without non-invasive ventilation in children with acute respiratory failure. In this study, they had 50 patients with acute respiratory failure. 25 patients were randomly allocated to NIV plus the standard therapy, which is the study group. And the other remaining 25 were given only the standard therapy, which is the control group. The conclusion or the finding of the study, the endotracheal intubation was significantly lower by 28% in the first group, the NIV group with the standard therapy, compared to the standard therapy alone. Another study also published in the intensive care medicine, a prospective epidemiological study trying to identify factors of non-invasive ventilation failure or to predict non-invasive ventilation failure. In this study, they had two groups, total of 116 patients. Group 1, ventilation perfusion impairment, was the main respiratory problem in this group, group 1 or type 1 group. And in the type 2 group, hypoventilation, which is something related to respiratory failure or hypercapnia, was the main respiratory failure, which is 78 episodes. Most common admission diagnoses were pneumonia, almost more than 80% in type 1, and the rest in type 2 group, they had 39% and 42% with asthma and bronchiolitis. Type 1 patients showed higher risk of an NIV failure compared to group 2, which is related to hypoventilation as a main respiratory failure. NIV sometimes is used. In this study, they concluded that NIV is used to support technique in pediatric patients. Close monitoring to adjust NIV setting is the key success to the application of NIV. So another study also in pediatric critical care medicine, predictive factor of outcome of non-invasive ventilation in pediatric with acute respiratory failures. This is a prospective, non-controlled clinical study aimed to identify success and failure, prognostic signs of non-invasive ventilation in pediatric acute respiratory failure. The age range, as you can see here, is very wide, between 1 month and 16 years, and failure was defined as the need of intubating the patient. 19% of the 47 patients needed tracheal intubation. Mean airway pressure, one of the factors for the outcome of non-invasive ventilation in pediatrics. Mean airway pressures during non-invasive ventilation, an FiO2 value of greater than 115 in mean airway pressure, and FiO2 of greater than 60% predict NIV failure. Also, another study published in 2011 regarding non-invasive ventilation on a pediatric intensive care unit. What is the efficacy and what's the visibility and predictors of success? This study was retrospective chart review in which they have reviewed charts from the year 2003 to 2010 in 8 beds pediatric intensive care unit, and 74 patients were treated with NIV. Intubation rates of the patient was 23% and mortality was 15%. However, when they conducted the multivariant analysis, they identified that the low pH or drop in pH after NIV initiation is to be an individual risk factor for NIV. So monitoring the pH to the baseline pH when we start NIV is one of the predictors or one of the factors that we may look at to predict NIV successfulness. So another study also in pediatric critical care medicine, safety, efficacy, and tolerability of early initiation of non-invasive positive pressure ventilation. and pediatric patient admitted with status asthmaticus. So in this study, it's a prospective randomized controlled trial. They included 20 patients, and again, look at the age, between 1 year and 18 years old. So this is very inhomogeneous, admitted to the pediatric intensive care unit with a status asthmaticus. Early initiation of non-invasive positive pressure ventilation along with the short beta agonist systemic steroids can be safe, well tolerated, and effective in the management of children with status asthmaticus. However, these findings were found in older children compared to younger children. So these findings may suggest that using the NIV to delay intubation in this population maybe is of an effect in older children. However, intubating a status asthmaticus patient should be carefully decided. Another study also of non-invasive ventilation in acute respiratory failure in children. And the aim of this paper is to assess the clinical efficacy of non-invasive ventilation in avoiding endotracheal intubation. So patients with acute respiratory distress treated with NIV and from a period of November 2006 to January 2010 in the intensive care unit. They included 151 patients with acute respiratory failure. They divided the patients into two groups, NIV success and NIV failure if the endotracheal intubation was required. Mostly, again, the main diagnosis was bronchiolitis in 67% of the patients and 29% with pneumonia. In conclusion, in this study, they concluded that NIV as a form of respiratory support, non-invasive respiratory support for children and infants with acute in avoiding endotracheal intubation. It showed some efficacy. Another also study published in Pediatric Critical Care Medicine, a comparison between non-invasive mechanical ventilation and standard oxygen therapy for children up to 3 years old. This is one of the studies that is specifically looked at a certain age group. So this study was prospective, and children between 28 days and 3 years undergoing invasive mechanical ventilation. Also, although they looked at this age, it's still it's wide range of age compared 28 days to 3 years. And they concluded there is no difference seen between groups of patients who were in non-invasive ventilation or patients with standard therapy. Another study also the efficacy of non-invasive mechanical ventilation in preventing intubation and re-intubation in the pediatric population. They concluded that in this study, although there were serious underlying diseases and differences in patients, in most of the patients, 70% avoided intubation with the use of NIV. Okay, the current or the literature that is provided in this presentation has a limitation. It's only one randomized controlled trial, and there is a wide range of age difference between participants. Most of the studies had a low sample size, inhomogeneous sampling of participants with underlying disease, and there is no study except one targeting a specific population, given the fact also this range of age is wide. So, as a respiratory therapist, when we initiate NIV, we need to have close monitoring to our patients to make sure what is our FiO2 setting in relation to our PO2, in relation to our saturation, what is going on with the patient. Sometimes when we set a patient on NIV, the respiratory therapist should grab a chair and sit next to the patient, monitoring him for the first 15 to 20 minutes to ensure proper breathing, making sure that the patient monitoring the mean airway pressures, also then doing blood gases to check the blood gases and the pH, also make sure that the patient respiratory rate, heart rate, vital signs. Close monitoring in the first 15 minutes is very essential. Also the interface to make sure that the patient does not have any leak, the patient is breathing comfortably, trying to make sure the interface is appropriate for the patient selection. So in the interface, we may face, if the patient stays longer time, we have to watch for that as a respiratory therapist. We have to make sure that no facial archal, make sure that there is no leaks, watch the patient closely during non-invasive ventilation to avoid any asynchrony with the machine. Also make sure that your setting does not compromise the hemodynamics. Sometimes the failure is not because of NIV, it's because improper application of non-invasive ventilation. So we have the nasal mask. You can use a nasal mask. It's less risk of aspiration, easier to perform oral suctioning or secretion clearance, and you have a listed space than compared to facial mask. Mouth leaks sometimes, higher resistance through the nasal passage for some children, nasal irritation and potential nasal obstruction. Also, the interface of face mask, of the full or the face mask, is control the mouth leaks to reduce the leak and better for mouth breather patients. More dead space, you are then claustrophobic with some patients, you might have high aspiration risk, and also greater sedation may be needed while the patient on the full face mask. So, summary of selection. Make sure you are not using the non-invasive ventilation when you reach a point of delaying intubation. If it fails, it fails. You have to make sure that you are using proper ventilator setting to avoid any asynchrony, to monitor also your measurements through the ventilator. Also, monitor the patient hemodynamics, monitor the patient's breathing, monitor the patient's blood gases. Make sure when to start it in comparison to when to stop the NIV, because delaying its intubation is usually associated with a worsening outcome. So, as a respiratory therapist, again, as a team member, working or applying non-invasive ventilation is the responsibility of a respiratory therapist. The respiratory therapist should make sure that he properly adjusts the setting under the supervision of a physician. He should make sure that he is monitoring his patients accordingly. And by that, I concluded my short presentation, and thank you again for having me, and thank you very much.
شكرا دكتور سعد الله يعطيك العافية. I'm not sure if you hear me.
I hear you, doctor. I can hear you.
Very good. Excellent. يعطيك العافية دكتور سعد. Well done. I think we'll move to the next speaker and then we'll have the discussion at the end. Is that okay?
Yes, it's up to you, doctor.
Very good. Then we'll make it like a panel discussion at the end. It will be much, maybe it's much better. Now we'll move to the next speaker, Dr. Khaled Alawam, Assistant Professor of Respiratory Therapy from NIV College. He's going to talk about the high flow oxygen. Please, Dr. Khaled, go ahead.
طيب بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على نبينا الأمين. First of all, I want to thank the organizing committee for inviting me. جزاهم الله خير على هذه المبادرة، مبادرة الوفاء للدكتورة مها الدباغ اسكنها الله فسيح جناته. أنا حصل لي الشرف العمل مع الدكتورة مها في مستشفى القوات المسلحة بالرياض. نسأل الله سبحانه وتعالى لها الرحمة والمغفرة والعافية، ونسأل الله سبحانه وتعالى أن يكتب لكم أجركم على هذه المبادرة الطيبة. I will try to talk today about high flow heated nasal cannula, and hopefully I will stay on track with the presentation time. And if I go overboard, then Dr. Adil, you're welcome to stop me at any time. What we're going to talk about today is looking at the history of high flow nasal cannula, and we'll see how it was developed and where it has reached. And we look at the mechanism of actions, which is very important to me as a physiologist. How does it help in maintaining the physiological parameters or physiological function of the patient? we'll look at the importance of heated humidification. If we have time, I'd like to talk a little bit about the use of high-flow nasal cannula in acute hypoxemic respiratory failure. And if we also have time, I'll try to present a few of the recommendations for the use of high-flow heated nasal cannula in COVID-19 patients. The early oxygen delivery systems, primarily the nasal cannula, was actually out there way before. You can see there on the left side of the picture here, what looks like a snake here was developed in the early 1900s, and it was a rubber catheter that was inserted into the patient's nose, and the oxygen delivered via that. In the 1920s, then pediatric care, what they call metal nasal cannulas, were used in pediatric patients. Obviously, they were cumbersome devices and they were difficult to mount on the patient and maintain. In the 1930s, they went back from the metal, they went back to the rubber systems. And, again, it was also somewhat cumbersome and it required a lot of maintenance on the patient. In the 1940s, that's the era when we started using PVCs, and and it went over the ear as opposed to around the face. So that was occurring in the 1940s. Now, when you look at the modern oxygen delivery systems, you'll see that we have a wide variety of oxygen delivery systems, and they range in flows from 1 to 6, all the way, if you use a rebreather mask, to a 10 to 15. And the oxygen percentage is also variable between these devices. The nasal cannula can provide oxygen delivery or FiO2 percentage between 24 to 44. When you use a tight-fitting rebreathing reservoir mask, you might be able to get up to 60 to 90. However, these were not sufficient enough to provide patients with enough flow and enough oxygen percentage, and they had a lot of disadvantages and complications with them. If you use a mask on a pediatric patient, they most likely will not tolerate it, and they're not going to keep it on their face, and you're going to be fighting with them and begging the mother to calm the baby so they can get enough oxygen percentage. So they had limitations, to them, because you're using a massive flow. Even if you use a bubble humidifier to supply the oxygen flow, you're still running the risk of drying of the airway. You have the energy expenditure in heating up oxygen, because the body has to heat up this oxygen that is delivered to it, and that is going to take some of the energy of the body. And if you have a very sick child, that's probably going to be very difficult for them. We talked about the patient discomfort and stress. The fact that you're not giving enough hydration is going to lead to thickened secretions, which will make it very difficult for the child to cough them up, and that may predispose them to higher risk of infection. There is failure to meet inspiratory demand. The flows that are delivered to the child may not be high enough, and the child may entrain air from the outside environment, which may dilute the oxygen percentage delivered. There is inaccuracy in oxygen delivery. All of these delivery or FiO2s that we talked about in the previous slide are based on some numerical calculations and some predictors that may not be true for all patients. There is multiple interfaces required. You have tubes, you have plastic, rubber bands that go over the face or around the nose and all these things. There's also the risk of treatment failure, which results in escalation of therapy, where you have to go, like Dr. Saad said, you may have to go to NIV, and then if the NIV failure, then you're going to have to go to a more aggressive therapy, such as endotracheal intubation. The concept of nasal high flow development is actually not a new thing. Its earliest development dates back to the 1960s, when these were makeshift devices. They were custom-made devices that attempted to provide high flows up to 30 liters per minute in the 1960s. Around 2000 was the advent of the modern high flow nasal cannula, which had the ability to provide flows up to 60 liters per minute via a specific nasal cannula attached to the patient's face, as you can see in the picture on the right-hand side. Now, these high-flow nasal cannula have a lot of functions and uses. The primary use for it is the respiratory support, which is, we're going to look at it, that it's going to help with the reduction of the dead space. And we'll look at its effect on dynamic positive airway pressure. We'll look at airway hydration. We'll look at the amount of oxygen being delivered. And finally, we're going to see how it impacts patient comfort. So the dead space, approximately 150 ml of inhaled breath is from dead space, and that's 1/3 of inspiration. And that dead space volume does not participate in gas exchange. So if that dead space ends up increasing, then you're going to have major effects on the gas exchange, where you would have the patient's PO2 dropping and CO2 increasing. So that's something we have to think about when it comes to oxygen delivery devices. Now, with the use of high-flow nasal cannula, you are sure to have a reduction in dead space, because that high flow is going to flush the upper airways, and it's going to remove any accumulated dead space that did not participate in gas exchange, which is going to be important because it will reduce the rebreathing of the gas, which is high in CO2 and depleted of oxygen. And if you achieve that with a high flow nasal cannula, you're going to get increased alveolar ventilation. Here is another, looking at some study that was published back in 2015 that looked at, using radioactive material to see the washing of the dead space. And you can see that when you use a high flow nasal cannula, you're actually achieving, quite a bit of, washing of the dead space. And therefore you are, purging the airways or the upper airways, you're purging them with fresh oxygen-rich gas, which will improve the patient's gas exchange. And you can see the difference here in an exponential rise in the oxygen percentage delivered to the patient. And if we go to the next one, where we have the effect of high flow nasal cannula on dynamic positive airway pressure, if you look at a patient who's unassisted breathing, on an oxygen device, a simple oxygen device, a regular oxygen device, versus a patient who's on high flow nasal cannula, you can see that the patient's tidal volume actually improve. And this is going to help when you have a patient who's breathing deeper, and slower. The distribution of the tidal volume they're receiving from a physiological perspective is going to improve. You're going to have improvement in the alveolar ventilation, and therefore that will enhance gas exchange. So this is a very, very important physiological benefit of using high flow nasal cannula to improve the tidal volume and the distribution of the tidal volume between alveolar ventilation and dead space, minimizing dead space and improving alveolar ventilation. If the patient starts breathing, like we said, slower, you have a longer expiratory phase, which allows for improved alveolar ventilation. And we can see here a patient who's breathing, unassisted breathing. And then if we're a patient who's on high flow, you can see the distribution of alveolar ventilation is actually greatly increased. And, the more fresh gas we can supply to the alveoli, the better the gas exchange we're going to have. This is a thoracic bioimpedance looking at the distribution of ventilation inside the chest using either, a low flow oxygen device versus a high flow nasal cannula. And you can see here, we have a very better gas distribution in the lung when we use high flow nasal cannula. That increase in lung volume is determined to be around 25.6%, which is quite good using this device. If we go to the amount of oxygen that is being delivered to the patient, if you provide, if you use a high flow nasal cannula, you can have, strong bit of confidence that you have a blended humidified oxygen. And if you look here at this patient who's breathing unassisted, then you can see that the distribution of oxygen only about 10 liters of the initial flow delivered to the patient is oxygen rich, whereas the remainder of the breath, the remainder of inspiration, has only about 22% oxygen, 21%. So this is, because most of the air is actually in the upper airway, has not reached all the way down to the alveoli. Whereas if you look at a patient who's breathing on a nasal cannula at about a rate of 35 liters per minute, you can see that the majority, if not all the breath, is actually oxygen rich. And therefore, that's going to ensure that this rich oxygen is actually receiving or going all the way to the alveoli and enhancing gas exchange. If we look at airway hydration and the role of high flow nasal cannula in that, we know that the system is actually called high flow heated nasal cannula. So it is actually running through a heater. And if we remember the first slide that I talked about, which is looking at the energy expenditure in terms of heating and humidifying the air the patient is breathing, with the use of this system, you're sure to deliver a temperature regulated oxygen flow with 100% humidity, and that's going to really improve the patient, would really ensure that the patient will not have to expand some of their energy trying to heat the air they are breathing. And that's going to emulate the natural balance of heat and humidity in the healthy lung. It will enable, enables the comfortable delivery of high flows, and it will also improve mucociliary clearance, something that we'd like to see with these patients. We don't want them to retain the secretions and then run the risk of infection. And if you look here, you have optimal humidity. It prevents desiccation of the airway epithelium, and it will improve mucus clearance because you're providing optimal humidity to the patient using this device. Patient comfort would be the last thing to cover in terms of this device. And we know that it's very comfortable and it's easy to use. There is no risk of claustrophobia. There is no risk of patient fighting because they don't have to put a mask on. Patient will be comfortably sitting. They can speak, they can talk, they can drink and eat. And, it's an open system, unlike Dr. Saad was mentioning a minute ago, where you have to have optimal seal. Here, you don't need to have optimal seal. The flow provided by the system is sure enough to, cover the patient's inspiratory demands, and therefore there is no risk of inhaling from the external environment and diluting the oxygen percentage. Numerous studies have looked at patient tolerance and have indicated that patients feel extremely comfortable with these devices. So if we look at the physiological outcomes for nasal high flow, and if we take them one by one, if we take the respiratory support, for example, here, we know that there is reduced respiratory rate, there is reduced carbon dioxide, and that's going to enhance alveolar ventilation, will improve the outcome of the patient. If you look at the airway, other things is there is reduced work of breathing, okay? There's increased tidal volume, so that balance between a reduced rate and increased tidal volume will ensure better or augmented alveolar ventilation. There is increased end expiratory lung volume, as we looked at. If you look at it from airway hydration perspective, there's improved mucus clearance. If you look at it from the supplemental oxygen, we know that it provides higher and optimal oxygen percentage. And for patient comfort purposes, the patient will sit here comfortably with this nasal cannula. They don't have to have a mask, tightly sealed around their nose or their mouth, and they're just going to sit there comfortably breathing with no issues to say. Now, what about the time it takes for the effect of high flow nasal cannula? What physiological improvement I'm expected to see in these patients? And for a reduction in heart rate, should that happen probably within 10 minutes, okay? And then we have respiratory rate should improve between 5 minutes to 15 minutes. Oxygenation should improve between 10 minutes to 15 minutes. In terms of patient comfort, I will talk about that a little bit later. You'll see that the patient dyspnea will subside within 10 minutes to 30 minutes. and supraclavicular retractions should go down by about within 30 minutes, and this asynchrony should disappear also within about 30 minutes. So much like Dr. Saad said, if I put a patient on these kind of devices, it needs close monitoring. So I'm going to sit next to the patient and I'm going to see how they're doing, watch them for about 10-15 minutes, make sure they are responding to therapy, because escalation of therapy is a possibility. So I have to be always aware of what's going on with the patient. Close monitoring is going to be very important for these patients. Now, the literature for high flow nasal cannula is expanding dramatically. We've seen that it has gone to about 160,000 papers, or 16,000 papers in the year 2015-2016. And I imagine with this COVID-19, if we look at the end of the year, by end of 2020, if we do a 1-year summary, we're going to see a much even higher number of papers that are related to this concept. And much like the video they're showing, the sands are moving. There is still a lot for us to learn. It's an ongoing process. We are benefiting from this, and we are still looking at its benefit for different patients, population, and different disease entities. For acute hypoxemic respiratory failure, I wanted to demonstrate to you the variability in these studies. There's numerous, like I said, you probably would come across 16,000 papers on high flow nasal cannula. And there is quite discrepancy between these papers. And therefore, when you are looking at the literature concerning this, you want to really look at it very carefully. Some of the studies you have to take with a grain of salt, and some are actually good studies. So this study here is a systematic review looking at the current evidence for the effectiveness of heated and humidified flow nasal cannula support therapy in adult patients. The literature for pediatric patients is much the same. But you can see here, the type of studies is different. Some are retrospective cohort, some are randomized clinical trials. Some have low number of patients, some have high number of patients. Some have, conflicting results, some support the same results. And, finding a study that would make you certain about whether to use this modality or not, it's going to take you some time to look for in the literature. If I add more studies here, you'll look here that again, we have some prospective cohort, and then we have retrospective cohort. We have some that have 38 patients, some have 20, others have 35. So you can see here that quite a lot of variability, even the outcome. And then you would have to see what is the primary outcome they were looking for, what is the secondary outcome they're looking for, and what is it really something I want to use? And I think Dr. Saad mentioned a very important thing, which is the heterogeneity of patients being included in these studies, and that's is going to take you quite a bit of work to find really something that fits your scope of practice. More studies. Here is a randomized controlled trial, a retrospective prospective score analysis, a retrospective cohort, 100 patients, 178 patients, 75 patients, and some say there is a difference, some say there is no difference. This is comparing high flow nasal cannula to NIV. And here they say that less septic shock occurrences, mortality of patients treated with high flow was 35 versus 57 for patients never treated with high flow nasal cannula with a significant p-value. Here, 62.7% of patients successfully avoided intubation, Apache score 2, the SOFA score, the cardiogenic pulmonary edema, and improvement in oxygenation within 24 hours were predictors of high flow nasal cannula success. One more study here is a retrospective cohort, 145 patients, and the findings is again, some say yes, Some say, la, wallah, it's not really something we want to look at. You know, maybe longer high CU and hospital length of stay, even after controlling for adverse events and mechanical ventilation. Yet continue with the same study. I just put there because to give you an idea that the literature there is very, very wide range. Now, one of the really good studies is this one, which is looking at high-flow nasal cannula oxygen therapy in adults with acute hypoxemic respiratory failure, which is a meta-analysis of randomized controlled trials. So that's a really good study. And I put here the diagram of, you know, their inclusion, exclusion criteria and how they actually arrived to it. And it was really, really good study. It was really designed well, was controlled very well. It was administered and done in a very nice way. And eventually they reached 6 studies were included only in this study. And this is a really, really good study. And you can see here now that, you know, the number of patients here is actually quite good. We have 310, 527, 105, 80, 40, 830. So there's quite a bit of data there to look at. And if you look at their control group, which is nice because because they are randomized controlled trials, they had control group. So this gives you an assurance of the outcome of the study that it is really quite a good study. And when you look at comparing, you know, the first 3 studies have had significant difference when looking between high-flow nasal cannula, conventional oxygen therapy, and NIV. The second study looked at high-flow nasal cannula versus conventional oxygen therapy. The third study looked at high-flow nasal cannula and conventional oxygen therapy, and they had a difference in terms of intubation required. There was a significant difference. However, the other 3 failed to show a difference in intubation required for these patients. Another study, which was a review article looking at high-flow nasal cannula versus conventional oxygen therapy and non-invasive ventilation, once again in adults, but the literature doesn't differ much between adults and, you know, pediatric. Really good study, nicely constructed, beautifully designed, and, you know, looking at comparing these modalities. Now, the data from the study is very rich. So they looked at high-flow nasal cannula, looking at with conventional oxygen therapy. This is looking at respiratory oxygenation parameters and respiratory rate, and the p-value was significant across the board. When they looked at the PF ratio, looking at high-flow nasal cannula with conventional oxygen therapy, again, the p-value was really good. When they looked at respiratory rate between high-flow nasal cannula and conventional oxygen therapy, it was a good, good result. So we know from this that high-flow nasal cannula compared to conventional oxygen therapy provides better or improved PaO2, better PF ratio, better respiratory rate. When they looked at the comparison between high-flow nasal cannula versus non-invasive ventilation, again, here there was an improvement that showed, except for one study that showed no significant difference. When they looked at the PF ratio between high-flow nasal cannula and non-invasive, again, 2 studies showed a good outcome. The third one failed to show difference. When you look at the respiratory rate, one study showed no difference, one study showed significant difference, the rest of the studies or the other 2 studies had no significant difference, but you'd have to go back and look at the exact data within there. When we look at the need for oscillation therapy between high-flow nasal cannula and face mask and non-rebreathing mask, if you look at the rate of escalation, looking at them, there is a difference, significant difference, at least in between the high-flow nasal cannula and face mask. There was no need to escalate the therapy, and that's something that should be added to the high-flow nasal cannula. There is no need for us to escalate the therapy and increase, keep going on the patient's support. When you look at the mortality, looking at ICU mortality, 90-day mortality, there's 2 studies here. Looked at high-flow nasal cannula with non-rebreathing face mask, high-flow nasal cannula and NIV. And if you look at the results here, The first study showed a significant difference. The second study had no difference, although we had to have to look at the odds ratio in these studies. When we look at the comfort of the patient, we talked about the dyspnea, the dry mouth, comfort of the patient, looking at high flow nasal cannula versus face mask. Studies showed that high flow nasal cannula was superior in decreasing the dyspnea and the dry mouth and improving the patient comfort. So that is something that should be considered when we are choosing high flow nasal cannula. Now for COVID-19, I just want to talk about a couple of minutes on that. Now, we know that the risk factor to respiratory failure for these patients is not clearly described in published reports. There is limited available data. We know patients who are older, male genders, presence of underlying comorbidities such as diabetes, malignancy, and immunocompromised increase the case fatality rate. The CDC indicated that the CFR of 2.3 with the CFR of 14 in patients aged 80 years or older, and the critically ill patients, the case fatality rate was actually 49%. And we know that the presence of pre-existing comorbid conditions such as cardiovascular disease, diabetes, chronic respiratory diseases, and hypertension, all of these and cancer increase the mortality rate in COVID-19 patients. If you go to Gattanuni work, he has published an editorial which is quite nice that described the phenotypes of COVID-19, and he had divided them into actually three. I'm showing only two here because they're pertinent to respiratory therapists, the L type and the H type. The L type are spontaneously breathing patients with Venturi mask. They have well-aerated and compartments of the lung, and you see the CT scan there shows very clear lungs, okay? And when we look at the PF ratio, we see that they have actually good PF ratio. Now, if you look at this H type, those are the very sick patients. Those are the patients who are going to end up on mechanical ventilation, prone positioning, probably even ECMO. And I was just reading a letter in one of the journals, and they said these L-type patients are hypoxic and texting. And when they say hypoxic and texting, they say these patients are sitting there with their mobile phones, sitting and texting and sending, Snapchats and, TikToks to their friends, not aware that they're actually hypoxic. And, they could have a saturations of 50, and these patients could drastically collapse, very shortly and present you with a big challenge. And, they termed that silent hypoxia. In terms of recommendation, if you look at two trials, the ICU ROCKS trial and the LOCO2 trial, from there, they had a consensus statement, which is the Surviving Sepsis Campaign Guidelines in the Management of Critically Ill Patients. And this guideline is a very cumbersome guideline, very long guideline, published very recently, and some of the publishers are actually world-renowned people who are here in Saad AlRabeeah, Dr. Al-Hazmi and Dr. Yasin Arabi. But in adults with COVID-19, we suggest starting supplemental oxygen if the peripheral oxygen saturation is less than 92%, although a weak recommendation, but low quality evidence as well, and starting supplemental oxygen if the saturation is less than 90%. If you have acute hypoxemic respiratory failure, we recommend SpO2 to be maintained no higher than 96%, and that's a strong recommendation with moderate quality evidence. For adults with COVID-19, acute hypoxemic respiratory failure, despite conventional oxygen therapy, we should switch them to high flow nasal cannula over conventional oxygen therapy. In adults with COVID, acute hypoxemic respiratory failure, we suggest using high flow nasal cannula over non-invasive positive pressure ventilation. And the reason is because you're worried about the patient aerosol generating because of the high pressure and exhaling into the environment and all that stuff. So if you put your patients on a high flow nasal cannula, those who are confirmed COVID patients who need oxygen, make sure they wear a mask, and they should tolerate wearing a mask over their nasal cannula, and hopefully that will prevent any dissipation of the virus. And they have a graph here where they look at, do you have a COVID patient with hypoxia? If yes, then indication for endotracheal intubation. Don't delay endotracheal intubation. Go for it. If they don't have the indication for endotracheal intubation, then you should start with supplemental oxygen. If they tolerate it, that's really good. If they don't tolerate it, then you should consider a high-flow nasal cannula. Now, if they don't tolerate high-flow nasal cannula, then your best option is to actually do endotracheal intubation. In summary, high-flow nasal cannula or high-flow nasal oxygen therapy allows delivery of heated, humidified oxygen at flow rates of up to 60 liters per minute. High-flow nasal oxygen has unique physiological properties. High-flow nasal oxygen can be used in a variety of clinical situations. However, I would caution that these patients need careful monitoring. So if you have a patient on these systems, you should monitor them very carefully. And the potential uses of high-flow nasal oxygen are still expanding, and we're going to go more and more, and we're going to learn more and more about this modality. This modality, as well as non-invasive ventilation, is becoming so popular that you find a ventilator which can deliver, a mechanical ventilation, non-invasive ventilation, high-flow nasal cannula, all at the same, within one device, where it used to be a separate device. Now they're actually integrating them into many devices to make it one device for one use. I want to say thank you to our heroes, everyday heroes, our healthcare providers out there in the front lines. You are doing a great job. جزاكم الله خير عن الجميع. تقومون بعمل رائع. نسأل الله سبحانه وتعالى أن يكتب أجركم وأن يجزيكم خير الجزاء. والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله, Dr. Khaled. Thank you so much for this very nice presentation, and I think it's very required and needed nowadays, especially when we are dealing with a COVID-19 pneumonia or any respiratory manifestation of COVID-19, especially the last few slides that you mentioned about the new approach of atypical pneumonia in COVID-19, or the atypical respiratory distress, acute respiratory distress syndrome, where you have to define exactly what stage that you are dealing with as a respiratory therapist in the ICU setting, because many studies that show when you are dealing wrongly with the case by giving a high PEEP or high pressure, probably you are shifting the lung to the more disastrous pathway if you are dealing in the L type and you have to manifest. So thank you so much. I think this is very important for our colleagues in the respiratory therapy department to consider it while they are dealing with any suspected case of COVID-19 presented with respiratory symptoms. I think there are a few questions, so I will leave it for you, Dr. Khaled and Dr. Saad, to answer them, and they are there in the Q&A, so you just click them and you answer them accordingly. Good luck, Dr. Khaled and Saad.
Yeah, Dr. Saad, I think the first few questions are yours.
Okay, I will start there. Thank you, Dr. Adel, and thank you, Dr. Khaled. So the first question is, what is the C-Flex? C-Flex is a comfort option that allows the respiratory therapist to sit on the machine, which will reduce the pressure during exhalation. So it's already set on the machine. However, the C-Flex, as mentioned earlier, it's allow you to set the option where it allows to release of pressure in order for the patient not to feel excessive pressure while exhaling. The other question here, it's also talking about the RAM, the rise time, and also C-Flex. The RAM, usually you sit. Let me get this one. Usually the RAM is the function enable the therapist to begin ventilation at a very low pressure in order to help the patient. So the RAM over period of time, the RAM time gradually increase to the setting that you sit on the EPAB and IPAB if you have bilevel during bilevel ventilation. The rise time in seconds is set how quickly your pressure is increased or reached from EPAB to the IPAB. So these are features that you use in order to increase the patient comfort and watch the synchrony between the patient. That's why it is essential when you hook up a patient on BiPAP is you monitor him, or CPAP, you monitor him closely. You grab a chair and sit next to him and look at everything. Look at the chest movement. Look at the way he's breathing. Synchronize his breathing with the machine. Look at the machine measurements, waveforms. It's also important now, my colleague, Dr. Khaled, talked about high flow nasal cannula. And in my presentation, I tend to touch on bi-level and sometimes maybe CPAP. It is important to know that when we talk about non-invasive respiratory support as a whole, nowadays there are three concepts under that: CPAP, non-invasive, which is bi-level, and high flow nasal cannula. So the initial setting of NIV, usually the initial setting of NIV during EPAB, you want to set a certain amount of pressure to keep the airway open, which is your EPAB is actually your CPAP in a kind of way. On top of that is the pressure you wanted to support the inspiration, which is another way is the IPAP. Okay. Maybe in my presentation I didn't touch on COVID-19. However, NIV, there is a great, as a non-invasive ventilation, there is a great disagreement in using non-invasive ventilation. However, there is a growing evidence to use of nasal flow, high flow nasal cannula, as my colleague Dr. Khaled mentioned. And I think by that, the next question is, can high flow oxygen? Okay, Dr. Khaled, I think question by Muhammad.
Okay, let me see.
Yes.
Dealing, do you have any guidelines? Let me see. Can high flow oxygen be used in cases of status asthmaticus, hoping to reduce the need to intubating the patients? I think Dr. Saad touched on that, where he looked at status asthmaticus patients with the use of non-invasive ventilation, and I imagine it's the same. It depends, again, it's on the patient's case and what you are looking at. The fact that you avoid intubation using high flow nasal cannula and you take it in a stepwise fashion in terms of escalating your respiratory support is essential, but it all depends on what is the case, how is the patient presenting. Are we talking about in the ER setting, or are we talking about in the ICU setting? But it is viable. It is a modality that can be used prior to the decision to intubate the patient until your adjunctive therapy would start and the patient's condition would start improving. And the next question, I don't know if he's meant to me or to Khaled Alawam, who's asking how to calculate the best flow for the patient range. Sometimes we will find it's very high for the patient and he's not comfortable. And yes, I don't think that the literature gives an exact recommendation for flows to start with, but you would have to start in an incremental fashion where you would put the patient on 10 and then keep going up until you reach your saturation level, and then monitor the patient's condition and look at not only the improvement in oxygenation. The improvement in oxygenation may take some time, but the patient's improvement in terms of respiratory rate, work of breathing, heart rate, and follow it very, very carefully. But I've looked at the literature of what is the optimal starting rate, and there's conflicting evidence there. And I think I put it back to what Dr. Saad was saying at the beginning, is when you have a wide variety of patients in different age ranges, it makes it very difficult for us to determine what is the best starting point. And do you think that it's beneficial that high-flow nasal cannula used with those whose mouth breather, as you showed, that tidal volume is getting better with high-flow nasal cannula? It's much like any other device, where if you have a patient who's a mouth breather and you're trying to provide oxygen using through a nasal cannula or the nasal pathways, you will not get much benefit in that. However, because it's not like a conventional nasal cannula, you have a very high flow there, that even if they were mouth breathers, the amount of flow that is going to purge or go into the airways is going to be sufficient enough. The effect is not going to be the same that you would see with a conventional nasal cannula for those mouth breathers. You would still get better oxygen, oxygenation in these patients, despite the fact that they are actually mouth breathers, because you are improving, or you're flushing that dead space and replacing it with fresh gas. There is a question here that says settings. What is the initial settings?
Yeah, in initial settings, for depending on which type we are using. Are we using the high flow nasal cannula? Are we using the CPAP or NIV? For NIV, as mentioned, if you are looking for bi-level, where you are setting your inspiratory and expiratory support, your EPAP, usually we start, there is no cutoff points where you start with 4, then you support him with 6, for example, as EPAP and IPAP. However, you monitor your patients, you monitor your blood gases and hemodynamics. This will give you the idea. Just to touch back on the features that the colleagues are asking, the C-Flex, most of them are improving the patient synchrony and improving the patient interaction with the machine. That's why it's important to look at them. The flex, the inspiratory device, and also the numb time, which is gradually opening, gradually accumulating, adjusting your EPAP and EPAP, which is expiratory positive airway pressure, and IPAP, which is inspiratory positive airway pressure. Something I want to share with my colleagues also is the update that is usually regarding the COVID-19 that comes from the Danox Academy. It explains, I can share it if you want to see it. It talks about everything, and it is supported what Dr. Khaled mentioned. High flow nasal cannula have growing evidence when it comes to the use for COVID-19 patients. So I will share this nice document with my colleagues. Just 1 second. Okay, I hope you can see this document. This is updated on May 7th. It's from the Ox Academy. It talks about it is very nice, handy documents that talks about almost everything that frontline, our colleagues in the frontline, God bless them, are working. So if we go all the way to item number 8, which talks about the high flow nasal cannulas and basically non-invasive respiratory support, I'm going there now to see with citations also. When it comes to high flow nasal cannula, there has been a growing clinical consensus to support use of high flow nasal cannula in some patients. These are all growing evidences and growing reports. When it comes to non-invasive positive pressure ventilation, or CPAP, non-invasive options, there is disagreement over the effectiveness of non-invasive ventilation by itself. In the form of non-invasive respiratory support, high flow nasal cannula is recommended, as mentioned by my colleague, Dr. Khaled, earlier. And again, I'm repeating myself many times. Sit next to the patient, make sure you know what is going with him, because saying the patient failed, let's intubate him, sometimes is not true because of lack of proper application of non-invasive ventilation or any form of non-invasive respiratory support. So let's look at the further questions.
There's a question from Saleh. What are the recommendations on flow rate and when needed to nebulize? Yeah, when needed to nebulize simultaneously while delivery, and how that affect the position. There is, again, in terms of recommendation for, what is the flow rate that you would start with. Again, the literature is widespread there, and I'm not sure that we have a common consensus statement that we can actually agree on. But I'm glad Saleh brought up this nebulizer because growing evidence is showing that you can safely deliver nebulized treatment to these patients safely using high flow nasal cannula. And the use of a mesh nebulizer seems to be the best option, since you're not adding to the flow that the patient is getting. And you're actually going to get really good deposition with these mesh nebulizers when combined with high flow nasal cannula. And recent studies now are also showing that you can use these high flow nasal cannulas to even deliver heliox therapy for patients with status asthmaticus. Some studies have shown that you can use it to even deliver inhaled nitric oxide. So like I said, the learning curve on these high flow devices is still there, still growing. And we're going to see more and more as we go through this. And then question is, what age cut can we use, and if we can prefer high flow nasal cannula than intubation? High flow nasal cannula can be used from neonates all the way to adults. That's in the literature there, and that's a standard practice. And yes, in many cases, you can avoid intubation using high flow nasal cannulas before you can actually intubate the patients. Depending on the patient selection criteria that you have, patient is able to breathe, able to maintain airways, then you're gonna have good success with that patient. Numerous studies have shown that the case or the reintubation in neonates and pediatric patients is also reduced with the use of high flow nasal cannula. So when you extubate them rather than putting them on a conventional oxygen device, step down is to go to a high flow nasal cannula. That's going to reduce the risk for reintubation, and that's there in the literature. Now somebody is asking for practical workshops, guides to application of non-invasive and high flow. I think that's a really good idea. Maybe we can ask our colleagues at the Saudi Pediatric Pulmonary Association, and would be really good to produce some audiovisual materials that actually is based on case scenarios and simulations on how to actually set these devices and put them together. The circuit sometimes can be tricky when it comes to setting it up. If you're using a ventilator with built-in high flow, that's easier to do. But if you buy the separate machine itself, it might take you time to put it together. But would be a very good recommendation to the Saudi Pediatric Pulmonary to expand on this e-learning and make them in a sort of audio-visual fashion, and add more practical sessions for that. Next is for you, Dr. Saad.
Yes, what is the question? Let me...
Using of NIV increases the risk of infection.
Yeah, this is what is mentioned in the document I'm sharing. They are stating this is may increase the risk of infection due to maybe humidification or aerosolized. However, it is still, we cannot say yes or no. It's a gray area that based on reports, and there is no supporting evidence. The argument is mentioning, do not delay intubation for any reason, as mentioned in section number 8. With high flow nasal cannula benefits over the NIV support, because if you reach a point of NIV with these type of patients, we don't know where we are going. Is he a type of patient that we want to prevent intubation, or is he a patient that needs intubation at this point? So again, no solid answer as to NIV is recommended or not.
Mm-hmm.
However, the solid answer is do not delay intubation in these patients.
Okay. Now, Mariam asked, what is the difference between high flow nasal cannula and nasal cannula? I suppose she's asking about the regular nasal cannula. Mariam, the regular nasal cannula, the maximum flow that you can start the patient on would be a maximum flow of 6, and your minimum flow would be 1. And you are not delivering high flow, so it's a low flow oxygen device. So it doesn't match the patient's inspiratory demand. The patient is going to inhale from the surrounding environment, and it's going to dilute the oxygen percentage you're delivering to the patient. And it does not provide heating. It does not provide humidification. If you use a passover humidifier, that's not optimal humidification. Optimal humidification comes from the fact that you're actually heating and providing the required humidity, and therefore you are reducing what we call the humidity deficit in these patients. The patients, if they are exposed to dry air, they're going to compensate from their own fluids in the nasal cavity, and that may lead to dehydration later on. And the fact that they have to heat the air they are breathing, that's going to require energy. That energy is in the form of oxygen. So you have already a patient who's hypoxemic, and you're asking them to give away some of their oxygen to, heat and humidify the air they're breathing. So with high flow nasal cannula, we are actually giving a patient oxygen delivery at high flow at body conditions, which is, temperature of 37 and 100% relative humidity. Abdurrahman is asking about the difference between the L type and the H type. And, L type and H type, these are phenotypes of COVID-19. When you're looking at patients who are diagnosed with COVID-19 due to exposure to the virus itself, the manifestation on the lung can be can put into categories, and the categories that they have arrived with based on Gattinoni's work. And we know Gattinoni is a very premier person in ARDS. He's the big person who talked a lot about ARDS management. He's from Italy, currently working in Germany, and he has divided them on 2 types, the L type and the H type. The L type are the patients who are, the lung is not heavily damaged, but the patient needs oxygenation. The body is unable to oxygenate enough. So, whereas the H type are the patients with severe destruction to the lung, to put it as simple as that. And these patients with H type, they are the ones that are going to go on mechanical ventilation. They are the patients that are going to require high PEEP, aggressive mechanical ventilation, are going to be your classical close to ARDS patients. Whereas the L type are the minor patients that the lung is not damaged so much, you need good oxygenation, okay? And hopefully, if you catch them earlier, you're going to be able to avoid them sliding from an L type to an H type. And I think that's what we are doing now. If you look at the statistics, the case fatality rate is decreasing. The number of people dying from COVID-19 has gone down to 15% worldwide, when it was about 27%. When you look at the serious and critical patients, it's gone down from about 27% or 32% to about 2% worldwide. And why is this happening? Is because our understanding of the disease process is improving. We are finding these patients before they get very, very sick. And that's making the difference in these patients' life. It's also reducing our stress on the healthcare system and improving the outcome of these patients. What are your thoughts on using high flow in hyperbaric respiratory failure? I'm not sure, hypercarbic, respiratory failure. More centers are using it in pediatrics if the hypercapnia is mild, and the data is very mixed regarding the ventilatory benefits of high flow nasal cannula. Bassem, I agree with you 100%. I think that's a gray area. remember, a high flow nasal cannula needs a patient who's able to breathe. And now, when we say we flush the upper airways or we flush the dead space, that doesn't mean that we are breathing for the patient. So you would have to look at your patient very carefully and decide on it. Now, anecdotally, and I will say this with quote end quote, some doctors would like to try high flow nasal cannula first before going into non-invasive or intubating the patient, because it's a safer modality. Patient may have success. Some reports have indicated, yes, it does help in the hypercapnic respiratory failure because it improves the alveolar ventilation, and therefore you get some removal of the CO2. Some have said no. If the patient does not have a maintained respiratory drive, they are not able to breathe on their own, their pH is below a certain level, then it's actually more dangerous. It's better if you can actually take these patients directly into mechanical ventilation.
One question.
Yes, Tadal.
One question I just saw, I'm trying to locate again. It's talking about when we fail, I think by Saad AlRabeeah. It says here, in case the failure of high flow nasal cannula to reduce the work of breathing, and we have some rise in saturation. So in this case, do we intubate, or we can try the other form of non-invasive respiratory support, which is NIV or bi-level? Now, your patient, initially, you selected high flow nasal cannula, and you reduce the work of breathing, and you improve the saturation. It means that your patient maybe is having hypoxemic respiratory failure. So if he failed high flow nasal cannula, you have to know why he failed. So is it recommended to go from a form of non-invasive respiratory support to another form of non-invasive respiratory support, making it 2 steps before the intubation? This is, in my opinion, is putting the patient into the delaying of intubation, which is associated with poorer outcome. So in this case, you have to know, why did you select high flow nasal cannula, for example, over CPAP or over NIV? So proper selection of the non-invasive respiratory support modality is very crucial at this time. Or we will start using maybe CPAP, he failed, using high flow nasal cannula, he failed. This doesn't allow us to use all the forms of non-invasive respiratory support before we go to intubation. So this should be carefully weighted by the respiratory therapist under the supervision of a physician, in order to come up with the proper selection of the non-invasive respiratory support modalities.
Okay. If a few questions here. Can we use high flow nasal cannula in the hospital floors? Definitely. The use for high flow nasal cannula can happen in many places, on the floors, in the emergency room, in the ICU. There is some evidence, and there is some evidence now coming up saying that even the use of non-invasive ventilation, CPAP, and high flow nasal cannula could be started even earlier at the ambulance when the patient is picked up from the home, or the injury area. Does high flow nasal cannula recruit alveoli? It's a very good question, and it's a very controversial question. We seem to think that if you use high flow nasal cannula, especially in neonates and small children, that high flow would produce some kind of CPAP. And there is a lot of evidence there that it says, yes, it does. And there is evidence that says, no, it doesn't. And when you trying to decide if it really works, does it really produce CPAP, you have to look at how they are measuring the intrathoracic pressure in these patients. So measurement of intrathoracic pressure can be done in many ways. You could do a strain gauge, which is just a belt that is surrounding the patient's chest, and you look at changes in pressure. Or you can put an esophageal balloon where you can actually measure the intrathoracic pressure. Depending on what they're using to measure the pressure, we can decide on that. Generally speaking, as a physiologist, I would say no. It does not produce positive pressure, okay? Unlike CPAP or NIV. Now, some clinicians would say, no, it does produce. And that's just something that I would have to argue with them as a physiologist, and, you know, my point of view as a physiologist and their point of view as clinicians, because it boils down to what we are measuring exactly, okay? If we're measuring the proximal airway, pressure, then we're gonna see pressure, obviously, because you're delivering high flow. High flow means pressure. But if we're measuring inside the chest, it all depends on what we are measuring there, and we would have to see what kind of patients. We'd have to look at abdominal pressure. If the patient has an abdominal pressure higher than the thoracic pressure, the pressure in the chest is going to be higher. Is this related to a higher abdominal pressure or high flow nasal cannula? So that's a point of debate. I don't think we're going to reach a common ground there. The risk infection for transmission between high flow nasal cannula and NIV, all studies have shown that the risk of infection is higher with an IV. Risk of infection with high flow nasal cannula is low, but make sure your patient is wearing a mask. They can tolerate a mask to wear over the device. That would reduce the chance of infection transmission. When do you recommend prone positioning with high frequency before going to intubating the patient? I don't know that there is a prone positioning would work with high flow nasal cannula. The Italians have said we should do it, and they do it a lot. Chinese said maybe, maybe not. I think if high flow nasal cannula is not maintaining a patient's saturation between 92 to 96 while they're in bed, comfortably sitting, then your best bet is to intubate the patient. If you're going to say, I'm going to get better oxygenation if I prone the patient with high flow nasal cannula, you're going into patient failing very quickly, and you won't be able to really pull them out from where they go. This is very careful. And somebody is asking about a negative pressure during high flow nasal cannula for COVID patients. No, you don't need a negative pressure. You need a negative pressure if it's an aerosol generating procedure. Bronchoscopy, you're doing the test for the patient and you're worried the patient can cough. You're doing secretion, suctioning, that sort of thing. You need a negative pressure, but here it's not an aerosol generating procedure, so you should be okay. As long as the patient is wearing a mask and you are wearing your personal protective equipment. Dalal, ya doctor, she's asking, use an IV with diaphragmatic hernia.
Okay. Now we have a diaphragm which is herniated. I don't think we need to deal with the first problem because we are not dealing. Now it's for the surgery time. But however, depending on the patient condition, he will be on oxygen because his problem is not respiratory failure. His problem is mechanical failure of respiratory muscles.
Okay. I think we go back to Dr. Adil since we have about 1 minute left.
Yeah.
For wrap up.
Thank you so much. It's really very great, and I enjoy listening to you during the presentation. I was really enjoying more during the discussion panel. It seemed to be there are a lot of questions still been left unanswered, but I will take it your suggestion, Dr. Khaled, seriously, that we will continue the air learning. It's just a start. It's just we started this process, and we have learned from COVID-19. COVID-19 caused a lot of problem, a lot of burden in economy as well as the healthcare system. But to be honest, we learned a lot from COVID-19. At least we learned how to deal with this e-learning, this nice softwares and programs to communicate virtually. There are a lot of topics that we should cover, I think, after Ramadan. One of them, management of asthma, management of child with severe asthma.
Yes.
And we'll take these questions which are not yet answered as a lead for us to build another seminar.
Inshallah.
Thank you so much. I would like to thank all of you, Dr. Khaled, Dr. Saad, Faisal, for organizing this webinar. All the attendees, اليوم you are يعني exceeding our يعني you exceed the numbers, which mean that people they really in need. جزاكم الله خير. تقبل الله من الجميع هذه الأيام الفاضلات، وأنا أعتبر هذه الصدقة أو زكاة العلم في هذه العشر الأواخر.
الحمد لله. الحمد لله.
جعل الله أجر هذه الأعمال لكم وللدكتورة مها في قبرها، يرحمها الله ويتقبلها بواسع رحمته ويرحمنا إذا صرنا إلى ما صارت إليه. في أمان الله، نستودعكم الله الذي لا تضيع ودائعه. إلى اللقاء. By the way, tomorrow there will be another webinar, cystic fibrosis, organized by the Saudi Cystic Fibrosis Group. It will be in the same time, 10 to 11:30, and the link has been already posted to all attendees. See you tomorrow. في أمان الله.
في أمان الله. في أمان الله.
في أمان الله.
الله يكتب أجرك.
الله يكتب أجرك. مع السلامة.